My name is Heun, I'm a consultant psychiatrist, hello, and I'd like to talk about the differential diagnosis of schizophrenia. We had a recent video where we talked about the diagnosis of schizophrenia and the operational criteria. And today I would like to talk about the differential diagnosis. Usually differential diagnosis is the alternative diagnosis, which might also be related or look similar to schizophrenia or other disorders. And so sometimes other symptoms and disorders can look like schizophrenia, and that's what we call differential diagnosis. And at the end of the video, you should know quite a few of differential diagnoses of schizophrenia. So from the previous video, you wouldn't be only be able to diagnose schizophrenia, but you would also be able to exclude other symptoms of other disorders which look like schizophrenia. So some of them are quite common: substance-induced psychotic disorder. So if people take short or long-term course of alcohol, stimulants, hallucinogens, steroids, antihistamines, and symptomatics, they can then induce the symptoms of schizophrenia. Very, very common is cannabis-induced schizophrenia or psychosis, and sometimes can be very difficult to distinguish a schizophrenia which is triggered by cannabis or a cannabis-induced psychosis itself. The other psychotic disorders which are related to medical conditions such as head injuries, CNS infections, CNS tumors. So sometimes a brain tumor can be the initial symptom or the causing symptom or causing disease of psychotic illness. So that's very, very common. Sometimes you can have post-epileptic states where people feel psychotic. Common is Jakob-Creutzfeldt disease, an infection of the brain, where the brain produces hallucinations in a quite strong way. There have been very interesting cases which look like schizophrenia, have been in hospital for schizophrenia for years, and the treatment, which is anti-inflammatory, has been overlooked. So the reason for the consequence of this is that people who have at least an atypical type of schizophrenia should be carefully assessed neurologically as well as with brain scanning. Okay, so the history is also important in general medical conditions. If someone has been abroad, has epilepsy before, or had endocrine disturbances, so then the likelihood that the schizophrenia-like symptoms are related to the brain disorder are more likely. Right, some mood disorders come with psychotic features. So sometimes people have nihilistic thoughts and feel nobody has any interest in them. They feel guilty about something that might not have been done. Very often, or in most cases, the delusions or the delusional psychotic features are mood congruent, related to the fact that people are feeling worthless. They have no contacts, nobody is interested in them, they can't eat, they can't drink, they can't swallow. So these things very often can indicate a mood disorder as a baseline. Some psychotic episodes don't fulfill the time criteria. In the previous video I talked about the fact that schizophrenia should last at least 4 weeks. Some people would say it should be 6 months. So everything which is shorter would be a pre-psychotic disorder or called a schizophreniform disorder. So more or less the criteria are there, but the time criteria are not clear about that. Sometimes we have psychotic symptoms when we wake up. So there are sleep-related psychotic disorders, which can be called hypnagogic hallucinations. So people hallucinate while they wake up, which then can be possibly seen as part of extended dreams, which go into wakefulness. There are other delusional disorder where the hallucinations are not a problem. It's no mood disorders, no real flattening of effect. It could be the fact about delusions about infidelity, delusions about having been the victim of theft, the delusion that other people influence them and they steal for them or talk badly about them. So these delusional or disorder are to be distinguished from schizophrenia, where we have hallucinations and visual and acoustic hallucinations. Sometimes these delusional disorders are much worse to treat because they go very much into the feeling of reality. Most people know that visual and acoustic hallucinations are not real, but the idea that other people look at them might be nasty, have bad thoughts about them, such delusional thoughts might be more difficult to distinguish from reality and paranoia. Right, dementia and delirium, we have other videos on that, but the fact is more or less that the delusions might be part of dementia and delirium. People in early stages of dementia very often feel that other people have stolen from them, and the fact is that they can't find things, and for that reason the best explanation for them is to say other people have stolen. Sometimes it happens that the late paraphrenia, or there is delusional disorders which develops as an initial symptoms of dementia or independently. So that can be sometimes related to people being very isolated, to age itself or aging itself, the loss of sensory input, so maybe hearing problems, so people get paranoid sometimes in these under these circumstances. So delirium is more a changing state, dementia is a chronic state. So that's one of the differential diagnoses of schizophrenia. You wouldn't expect anybody developing schizophrenia itself in the 60s or 50s, 60s or later, but that might happen. Right, okay, other symptoms might be body dysmorphic disorder. We would call this a paranoia or delusions which are related to the body. So people might look themselves as ugly, or might have body disturbances and focus their lives about disformations of the body, ears or whatever, noses, and that's might be delusional, that people have influenced that or have an impact on that, but usually the focus is the body and not the schizophrenia, not hearing voices. Sometimes people have symptoms of schizophrenia and post-traumatic stress disorder. Usually there should be a relationship to a specific time when this has developed, but usually it's quite different, and the symptoms are not as clear-cut as in schizophrenia. Some people might have, or children, there might be some disorder, what we call pervasive development disorder, where there is early dysfunctioning in the mental health, where also some paranoid symptoms and some abnormality in hearing voices or some minor hallucinations might exist. Obsessive compulsive disorder is a differentiation from schizophrenia. Might be that people are focusing on the fact that other people have stolen from them, or are cheating, or are doing other things or speaking about them. And the question here is not the thought or the content, it's the fact that people can't stop thinking about that. So there are these endless ruminations which more or less drag the diagnosis from a delusional disorder into an obsessive compulsive disorder. So it's more or less how things are dealt with or how things are perceived more than what they are presenting in which way. People who are very hypochondriac can present with very strange symptoms, very uncommon, but it might happen. Some people might have a personality disorder where they are consistently paranoid about other people, so they always have the feeling other people are against them, are doing things against them. They might have a constant suspiciousness and distrust to other people, and find causes on reasons to feel like that. Schizotypal disorder or schizotypal personality disorder is more or less related to the odd or eccentric behavior, which sometimes can be very typical of people with schizophrenia. Sometimes people with schizophrenia dress very odd, very sparkling, but sometimes don't have the money to be very, let's say, very well dressed. Sometimes, we have induced or shared psychotic disorder, which is not the most common, but that it happens when very close friends or relatives take up believingly or just indirectly, without really properly believing, into the delusions of the patient, but sharing them just to support the patient. But it's not really clear whether they really support the patient or make things worse. And there's some question about being co-diseased. Right, misidentification syndromes is usually very common or easily confused with delusional disorders, so that people might not identify other people properly. And so that's not the most common, and usually it's quite easy to distinguish from schizophrenia. I said before in this and previous video that these very abnormal feelings which happen in schizophrenia and other disorders cause anxiety. So people very, very often have anxiety, severe anxieties, and being very concerned, being very anxious, very agoraphobic, so that they don't want to go out. And sometimes the fact that they don't want to go out has no clear reality, and then there might be some problems distinguishing it from schizophrenia. Factitious disorder is when people try to show and feign disorders, and they're related to what they call Munchausen syndrome, and sometimes it's just the benefit of getting money or other advantages by having a disorder. Okay, so this is differential diagnosis. Usually the symptoms are different, the timing is different, and the intensity of the delusions can be very much different from these disorders. Okay, if you're interested to hear more about mental health problems and to learn about more, I hope you subscribe to our channel, Global Psychiatry Archives, and I hope that my promise that you will learn a little bit about the differential diagnosis of schizophrenia has become true. Thanks for your interest and have a nice day.